do rice tube is not essential, but may be of value in patients with vomiting, as per the book. But as the patient comes to you in the casualty, what you do, rice tube, you have to put the rice tube.
Everyone, I'm Sneha, finally a medical student from SABB MCRI Bangalore. We have Dr. Rohan, who is a surgery resident. So today we'll be having a session on acute pancreatitis.
So thank you so much, Sneha. So today we'll begin with the session that the topic is acute pancreatitis. I will just share my screen. So we have the topic here is the acute pancreatitis, and okay, let's begin. Before beginning, I will just tell you anatomy of the pancreas. Pancreas is basically a retroperitoneal organ, and as you can see, it is situated below the liver. Below the liver and behind the gallbladder and all area, it's a retroperitoneal organ. So what here we can see, we have the pancreas, we have the four parts. First is the answering process, then we have the head, neck, and then the body and the tail. So with the answering process and the body is present, we have a dual blood supply. So at first, overall, the blood supply is the splenic artery and as well as the splenic vein. But at the starting point, that is at the incident process, there is a dual blood supply. That is first is the splenic vein, splenic artery, as well as there is a gastroduodenal artery which supplies the head. So moving on, we have one ampulla of Vater. The ampulla of Vater is the basically area where both the gallbladder, that is cystic duct, forming the common bile duct will secrete as well as the pancreatic duct will secrete at this area. So all the pancreatic enzymes as well as the bile enzymes will be secreted at the ampulla of Vater, where the sphincter of Oddi basically is the sphincter that will not allow the enzymes to flow up to the duodenum. That is second part of duodenum. So basically, the sphincter of Oddi divides the duodenum into two parts. We have the foregut and the midgut, which it divides. So in the foregut, we know it's the celiac artery which supplies, whereas in the midgut, we know the superior mesenteric artery which supplies the midgut. So moving on, next we have is introduction. So what is pancreatitis? As the name suggests, it's an inflammation. So where is the inflammation? Inflammation is basically in the parenchyma of the pancreas. So when we call it as acute pancreatitis, we call it when we have an abdominal pain. There are many other symptoms like abdominal pain, nausea, vomiting, and there is also increase in the enzymes, that is the pancreatic enzymes, amylase, lipase, and we have the CCT findings on the USG findings. Moving on, pathophysiology. So what causes it? So pathophysiology basically what causes there is one mechanism that is called as autodigestion. So here what happens, the enzymes which are secreting to the pancreatic duct, they get blocked by the gallstone or any other means like a carcinoma or something which are present in the pancreatic duct. So it will cause the pancreatic enzyme to secrete, but it will not go to the duodenum or any area, which will cause autodigestion. So what all happens here is we have the sinus cell injury, which impairs the secretion of the zymogen granules. We have a duct epithelium injury, which basically delays the enzymatic secretion. So overall, what happens because of inflammation, we have the edema, hemorrhage, as well as the at the end necrosis will occur. Next. Yeah, it's a flow chart basically. What is the causes of the acute pancreatitis? We have the pancreatic duct obstruction. As I told you, it's a common bile duct stones or any tumors. Another is we have some hyperstimulation like alcohol, TGA. We have some medicine also which will lead to acute pancreatitis. Like the common one is the isoniazid, which is in TB, metronidazole. Then we have the furosemide, that is a loop diuretic, etc. Then other what we have is the reflux. It's also a mechanism. We have the reflux of the infected bile. And all the duodenal contents, basically it's going back, not going to the duodenum, it's going back to the pancreas, which will cause this. Then we have the defective intercellular transport and the zymogens. So zymogens basically which will stimulate proenzymes. In the end, the proenzyme will cause the activation of the enzymes, that is the amylase and lipase mainly. So which will again cause that secretion of the trypsin inhibitors. Basically, overall, what it is, there is a increase in amylase lipase, that is the own enzymes, and as the pancreas cannot keep the own enzymes in the pancreas itself, it will cause inflammation. Then, yeah, we have the systemic complications also of acute pancreatitis. What happens is all the inflammatory mediators are also released into circulation, which will cause hemodynamic stability, sepsis. Then we have the ARDS, pleural effusion, GI hemorrhage, renal failure, and DIC. Basically, these all the inflammatory mediators are released in the state in the circulation, causing renal damage and other organ damage. So it's a multi-organ damage at the end in severe cases. Then moving on, we have the early and the late phase. In case of early phase, it's basically like within a week, and late is after that week. So early phase, what happens is it is characterized by SIRS. What is SIRS? As you all know, it's basically inflammatory response syndrome, systemic inflammatory response syndrome, which, if it is very severe, as I said, it can lead to organ failure. So about one third of the deaths occurs in the early phase, and the rest occurs in the late phase. So in late phase, if it's a very severe attack, which will run from weeks to month, so what happens? There is persistent signs of inflammation, which is chronic in nature. And the local complications we have is fluid collection that is in the around the pancreas, and we have the peripancreatic sepsis. Moving on, classification. There is one more classification, that is the Atlanta classification, which I will discuss later. But in short, there are two classes. There is one classification here, that is mild and severe. In case of mild, there is only edema present, and there is minimal organ damage, but mortality is only 1%. Whereas in severe, we have the 5 to 10% mortality, and necrosis will happen in this case, causing to SIRS and multi-organ failure. Here, the mortality is 20 to 50%. So, then, what is the etiology? So there is a mnemonic like I get smashed. So most common we have the gallstones, then we have the alcohol abuse, that is ethanol and all. Then we have trauma, idiopathic is also there. Steroids, mumps, autoimmune, scorpion bites. We have the hypercalcemia and hyper TGM. Then ERCP. ERCP is a iatrogenic cause. We have the drugs and medication, as I said already. That we have the furosemide, metronidazole, NSAIDs, which will cause. So the most common is biliary calculi, that is 50 to 75%. Moving on, clinical features. The main clinical feature is the pain. We have the severe pain. In acute cholecystitis also we have pain, but in this case it's the severe pain. And to differentiate acute cholecystitis from acute pancreatitis, we have to do as USG or CCT has to be done urgently. So yeah, the pain will be very much severe, constant and refractory, and that is not basically refractory to the usual dose of analgesic, localized to efficacy or can be diffuse. But yeah, it's the very much typical finding in acute pancreatitis. It is radiation to the back, 50% cases, but yeah, relieved on sitting or leaning forward. So normally you will see a patient who is sitting leaning forward in case of acute pancreatitis, but it is only in 50% of the cases. So you have to do an investigation to prove that it is acute pancreatitis. So investigations, the main investigation is amylase lipase, and like a CCT or USG has to be done. And nausea, vomiting, retching will be present, but it's not diagnostic for acute pancreatitis. Then on examination, you will find it's a very toxic and sepsis look of the patient. And all the vitals, when you check, it's a hypotension, tachycardia, tachypnea. Temperature will be rise because inflammation will develop, and itching will only be present in case of gallstone. Otherwise, it won't be present. Moving on, now it's a typical feature, bleeding. That is a bleeding into the facial planes. Because of the hemorrhage, because of the hemorrhagic in the pancreas, there will be bleeding in the surrounding areas, as well as what happens here, the capillary will break. Your capillary breakage will lead to bleeding. So when I will show you the image once. Yeah. So yeah, when you see in the around the umbilicus, we have the Pullen sign. When you see it around the flank, that is the J. Turner sign. And fourth sign is also there, which is in the inguinal region. So what you will see, muscle guarding is also present in the upper abdomen, which is not that typical for this, but yeah, pleural effusion can be seen in case of 10 to 20% cases. Then investigation. So yeah, we have the amylase and the lipase, but amylase is not that much specific because it's also seen in other cases, like we have the perforation, infarction, mumps, and other cases, whereas lipase is very much specific for pancreatitis, for pancreas. So yeah, amylase, we have the threefold increase in the normal values. But yeah, in this case, it returns to the normal after 72 hours. So basically, if you have a patient coming to you with after 73rd day, so amylase will be normal, but your lipase will be remain high at till 7 to 14 days. So yeah, there is a persistent elevation. We have the pseudocyst, we have the local complications. Pseudocyst, abscess, or non-pancreatic causes can also be there, like obstruction, mumps, and narcotics. In that case, that's a chronic pancreatitis. That's a different topic altogether. So yeah, lipase it's a diagnosis, 7 to 14 days. Other findings are not that much diagnostic, but yeah, you can find it out. WBC will be raised, glucose will be high, BUN will be elevated, calcium will be low. See, the cause is for calcium is hypercalcemia. You can see hypercalcemia is a cause for acute pancreatitis. But when acute pancreatitis occurs, you will see there is a hypocalcemia. Why? Because of the saponification. Saponification basically there is a fat necrosis in case of acute pancreatitis. So all that calcium leaks out of the cells. So basically out of the cells and the blood also. So basically hypocalcemia will be developing because when you see the HP or the biopsy of the pancreas, you will see there is a white spots all over the pancreas. That is the calcium deposition. There will be a hypocalcemia. Then we have the bilirubin, alkaline phosphatate, and all that will be elevated. ALP is basically elevated in case of biliary 3, that is a CBD obstruction or CBD, yeah, obstruction. So yeah, aluminum will be low in of 10%, not that much specific, but it indicates acute severe pancreatitis. Then we have the elevated LDH, which suggests there is a poor prognosis. Then CRP, as you know, it's an inflammatory marker, so it will be raised. And ABG will show hypoxia of sepsis. You have to do all that things. EUS, what is EUS? It's endoscopic ultrasound and MRCP. MRCP in case of CBD dilatation or CBD stone. So radiological signs are also present in HCA, but that are not specific. But yeah, you can just remember colon cutoff sign, gasless abdomen, sentinel loop sign, which is also seen in focal dilated jejunal loop. Then yeah, the main thing here is CCT. In daily and lab, what they have given is CCT done after 72 hours. But in general practice, what we do, when the patient arrives, we do a CCT. So what is the reason for CCT after 72 hours? It's basically for prognostic factors. It's after 72 hours, the prognosis will be very much but clearly visible in case of CCT. And then what is the most sensitive part of this is portal venous phase in CCT. That is the most sensitive for necrosis. Then we have the indications for CCT. What are the indications? So if you basically normally for all acute pancreatitis we do a CCT, but yeah, as per the book, we have to do only when we cannot distinguish between interstitial as well as necrotic pancreatitis. If you don't know or the diagnosis is not confirmed, or there is a sepsis organ failure, or it's not managing with the medications, or there can be a localized complication like pseudocyst, we have pseudoaneurysm. So yeah, in this picture you can see there is a cross mark. Basically, it is showing acute necrotizing pancreatitis. There you can see there is a edema all around the pancreas. So that picture is, it has been shown in the CCT picture. The scoring system, what we have is the most common, we have the Ranson and the Glasgow scoring system. Others also we have the Bishops like Apeke, SAPS, SOFA, MODS. But yeah, in general practice, we have the Ranson and Glasgow, which is basically more than 3 if it is after 48 hours, it indicates a severe attack. But what are the disadvantage for the scoring system is they are telling that we have to do it after 24 hours, 48 hours, and 7 days after admission. But we cannot wait till that. So the scoring system is basically for the prognosis and the management. But at first we have to initiate the emergency resuscitation. So yeah, it is the answer and the Glasgow scoring system. Basically, what they have the criteria, what they have kept is the age, WBC, glucose, LDH, AST. In both the cases, you can see there is only very much some variation, not that much variation. But yeah, in Ransom, we have on admission within 48, whereas in Glasgow, we are only within 48 hours. Another criteria, we have the hematocrit, BUN, PaO2, calcium, as I said, base deficit, and fluid sequestration. So we have to remember, but yeah, in clinical practice, we don't generally use this. But yeah, next we have the Atlanta classification. So Atlanta is divided into three things. That is a mild, moderate, really mild and severe. Then we have the moderately severe and the severe. So what we do in mild, it's very simple classification. Mild is no organ failure, no systemic or local complication. Whereas in moderately, we have the organ failure, but it's transient. Whereas local and complication can be present. And whereas in severe, it's both. We have the organ failure also, we have the local complication also. We have the single multiple organ failure. Then management, how will you manage a patient? So if a patient comes to you with this in the emergency, you cannot differentiate between acute cholecystitis and acute pancreatitis till amylase lipase is present with you. If you have the amylase lipase reports, you can differentiate. Within cholecystitis, you won't be seeing any rise in amylase and lipase. Then management, yeah, if it's a mild case, if the symptoms are not that much severe or the patient is stable basically, there is no tachypnea or something, vitals are stable. So you have to patient have to be kept in NPM, then IV fluids. Analgesic antiemetic has to be given. Antibiotics are not indicated. See, in general practice, what we do, every patient we give antibiotics, but according to Bailey and Love, antibiotics are not indicated in case of mild case. Yeah, and then CT scan is not necessary unless there is an evidence of deterioration. But yeah, in what we do in hospitals, we go for CT in the first day only. Yeah, but it's a different thing. Yeah, okay. Then rice tube. So what we do, rice tube is not essential, but may be of value in patients with vomiting, as per the book. But as the patient comes to you in the casualty, what you do, rice tube, you have to put the rice tube because what we have been taught is because to give the pancreas rest, there should not be anything in the stomach. Because if there is anything in the stomach, what will happen? It will give a pressure to the pancreas. But yeah, but according to the book, it is just a hypothesis, nothing like that. So you have to only give when there is vomiting, but we give it. So, but then we have the regimen. What the regimen they have given is for only for prophylaxis. That is the cefuroxime, imipenem, ciprofloxacin plus metronidazole, and that too it can be given for only 14 days, not more than that. But we start with meropenem only. And it can be cefuroxime is it's a low antibiotics. Imipenem can be given, but generally we start with meropenem only. So yeah, severe we admit the patient in ICU. Adequate analgesia, aggressive fluid resuscitation has to be given. Yeah, analgesia is very much important. We cannot give PCM in this case because PCM won't suffice the pain. So PCM cannot be given. We can give tramadols. Opioids can be given. Morphine, yeah, morphine is a contraindication, cannot be given. Otherwise, fentanyl can be given. So what happens? So when a patient comes to you, you have to start with that all that analgesic Dynapar you can give. But if the patient is not sufficing, we have to increase the analgesia. Because what we have seen, but not I have seen, but what our professors have seen that sometimes the patient die because of pain. Because of pain, acute pancreatitis patient have died. So analgesia is very much important in this case. Vitals are important, our urine output, catheterization we do. See, when a patient comes, rice tube and catheter is very much important for fluid intake output, CVP. Oxygen, if there is a low SpO2, and then other, we have the investigation should be managed, like calcium, magnesium, clotting factors and others has to be managed. Then yeah. So if we have the gallstone, if we see there is a gallstone in the USG or gallstone history is there, we have to take the patient to the higher center if the higher center has ERCP in that place only. In like common hospital, we won't find ERCP, but yeah, in the gastro department, we have the ERCP. Urgent ERCP has to be done within 72 hours if there is a gallstone. Because the cause of this has gallstone was there because there will be multiple small gallstones. The gallstone have left the gallbladder and it has gone to CBD as well as it has obstructed the pancreatic duct. So that's why ERCP has to be done urgently. We have the complications. Complications we have these are the systemic complications: shock, renal failure, hypoxia, hyperglycemia, hypocalcemia. See, hypocalcemia, as I said, it's into fat necrosis. Hypoalbuminemia permeability will be increased, so that way then hypoxia. These are all basically inflammatory markers in the systemic circulation. ARDS will count microthrombi, and renal failure. Uh, there is a there is a pressure symptoms of the pancreas as well as the fluid-filled loops of the bowel leading to pre-renal azotemia leakage. Then moving on, we have the GI. GI is basically upper GI bleeding, duodenal obstruction, obstructive jaundice. Upper GI bleeding is basically due to the erosion, whereas the duodenal and all that is basically due to the that. Basically, pressure symptoms are causing all this. Pressure symptoms. Then we have the local complications. We have the necrosis. We have the abscess. In general, in any abscess in the body, you will see a rising fever, WBC count, WBC count, localized tenderness, and there will be a pleural effusion because of the, and I will tell you later, pleural effusion basically because of there are two things, the main mechanism for pleural effusion. The most common mechanism is like basically there is a fistula formation, which I will be discussing later. Then we have the pseudocyst. Pseudocyst basically is the encapsulated fluid. It is after it's some basically complication, chronic complication, not an acute complication, but it develops. What happens is less than 6 centimeter pseudocyst resolves spontaneously, but it's when there is a chronic complication, it will not resolve. So we have to drain the, if there is an infection, we have to drain. Otherwise, it's a very much sterile fluid. Ascites. Ascites can be seen because of the pancreatic rupture. Basically, permeability will be increasing. The leakage from the pancreatic duct, or there can be a drainage of the pseudocyst into the pancreatic cavity, which will cause ascites. Then, how will you manage symptomic management? The organ failure. Hmm. Then we have the systemic management. If there is an organ failure, we have to give supportive therapies, right? All that. If there is a renal failure, we have to do dialysis and all that, ventilative support. So basically, systemic management, we have to do supportive therapies, we have to do. Then we have to interventions. Surgical interventions are only needed when there is a result of local complication. If the local complication deteriorates, then only we will do. Otherwise, we don't do the surgery at this stage. We will just manage the patient and stabilize. Then we can think of any surgery. Then local management. So local complications are very much serious and has significant mortality. And conservative management with surgery only to the conservative if the management has been failed. So locally is more important than the system. System we have to manage supportive therapy. Then these are the local complications. We have the acute peripancreatic fluid collection. Then it's basically it will happen early in the course of mild pancreatitis without necrosis. And what you will see, there is a fluid accumulation around the pancreas. It's a very much sterile fluid, and it will not it will dissolve on its own. Most of the cases, no intervention is required. Only and only if it is it's very much large and causing pressure effects, we have to aspirate it under the ultrasound or CT guidance. Then one more we have, that is the transgastric drainage under the endoscopic ultrasound can be done. Then we have sterile and infected necrosis. See, sterile, if it's very much it's sterile, then no need to do. So what happens here? Diffuse or focal area of non-viable parenchyma. Typically, there will be pancreatic fat lysis. Then there are two terms, that ANC and WON. It's important. ANC is acute necrotic collection. What happens here is there is no wall, there is no capsule-like thing. It's only a intra or extra pancreatic collection containing the fluid and necrotic material. There is no wall. But after 4 weeks or in the period of 4 weeks, there is a well-defined inflammatory capsule, which will lead to pseudocyst. Pseudocyst basically it's a very much encapsulated fluid-filled collection around the pancreas. So yeah, if it's infected, we have to do something for this. That is, percutaneous drainage of the infected fluid should be carried out, and we have tube drainage also. Tube drainage inserted with the widest bore possible. So often repeated imaging and often repeated insertion has to be done to drain this. And if sepsis develops or if sepsis worsens, we have to do a pancreatic necrostomy. Has to be done. So it is the only surgery we can do, or otherwise only drainage or conservative management. So what is necrostectomy? If the condition worsens, we have to do necrostectomy. That is what we'll do. There are two ways of doing. If it is around the head of the gland, or if it is around the body and tail of the gland. So if it is around the head, we have the midline. We'll do go straight with the midline laparotomy directly. Or if it's in the body or tail side, that is in the back. So we will go from the back side, that is on the flank side. Left flank incision we will take. So once necrostectomy has been completed, further necrotic tissue may form. So the surgery is very much non-satisfactory and incomplete surgery. So repeatedly we have to do. So what happens after the surgery? We have to put, suppose in this case, we have kept two drains. We have a closed continuous lavage in this case. So what happens is we have two drains kept. See, this one and one more is from this. So if one drain sheet goes, another drain sheet comes out. Simultaneously we do. So what happens? Tube drains are left in and the raw area flushed. And then we have the closed drainage. Closed drainage in this, what we do? Incision is closed, but the cavity is kept with the gauze filled Penrose drains, and closed suction has to be done. Basically, what I'm telling is the drainage technique. After the surgery, you have to keep the drains. And how the drains, because it takes a long time for healing. Then we have to open packing. Open packing is basically how you do the normal dressing in the ward. What you do, incision is there, you keep it open like that only, with the intention of returning back to the operating room at regular intervals and repacking and again cleaning it. Repacking, cleaning it. That is the primary healing, you can tell, in pathology or even surgery also you have learned. Then the closure is the laparotomy. So what we do is we will just incision is closed in this, then we will kept with the intention of performing the laparotomy. So again and again, we will go to the OT after every 48 to 72 hours, and again you will see that if the granulation tissue has been formed or not. Really, it's a not satisfactory surgery. The problem here is because of the pancreatic enzymes it will releasing, it will not heal very much easily. The enzymes releasing. So again and again, you have to keep the drains, you have to rewash the area, rewash it so that the infection subsides. Then we have the pancreatic abscess. So what happens here is it's a collection of the pus, usually around the pancreas only. What we do a drainage with the widest bore possible. Again, the same thing under the imaging guidance, along with the antibiotics and supportive therapy you can have. Then pancreatic effusion. Pancreatic effusion is basically because of the pancreatic fluid effusion is occurring. So what happens is there is concomitant ascites also can be seen, and there may be communication with the intra-abdominal collection. So here basically there is a fistula formation. General mechanism is fistula formation between the pancreas, and there is a subdiaphragmatic fistula formation, you can say. And one more reason we have, there is a leakage from the pancreatic duct. There is a leakage, and the leakage, there is a increase in permeability, which will cause the effusion. Which will cause the fluids to the leaking, to leak in that area, causing fluid effusion. Then what we do? Yeah, peritoneal drainage under imaging guidance is necessary in this case. Next, portal or splenic vein thrombosis. So it's a very incidental find, and it's only identified on a CT scan. So it's silently developed silently, and there will be rise in the platelet count. So conservative treatment has to be done. But yeah, if there are cases like if you see varices or any manifestation of portal hypertension, we have to give the treatment like endoscopic injection. What we do generally, binding, beta blockage, etc. Yeah, thank you. Thank you so much. Yeah, moving on to the questions.
Yeah, as you said, so there are more than 50% cases of pancreatitis is due to gallstones. So, is there anything that one can do to prevent pancreatitis once they know that they have gallstones?
Generally, what happens in 80% of the cases of gallstone is asymptomatic. So whenever you come for diagnosis with this, you have the incidental finding of gallstones. So many of the time, what we do, we advise the patients to do a cholecystectomy. So if there is a severe cholecystitis, that time we generally don't advise. But in higher center or very good center, we have to do early laparoscopic cholecystectomy. But in this case, to prevent acute pancreatitis, we have to do cholecystectomy. And if it's a very much multiple and small stones, which can lead to go to the CBD and then to the pancreatitis, we have to do a cholecystectomy in this case. Yeah.
Okay. Then, if gallstones are the cause of attack, is it necessary to carry out cholecystectomy immediately after the subsidence of symptoms, or after how many days is it done usually?
Basically, whenever something inflammation occurs in the abdomen, we should wait for the inflammation to come down. If you have very much good instruments or equipments and very much experienced surgeons, we can do. But if you are in the low setup or sometimes, so we have to wait minimum at an interval of 6 weeks. So generally in cholecystectomy also, when there is an inflammation or acute cholecystitis also, when you see, we generally wait for 6 weeks and we do a late cholecystectomy. In this case also, we have to, for pancreatitis also, we have to wait for around 6 weeks. So the inflammation comes down and there are least chance of any complications. So after 6 weeks.
Okay. So, why does pleural effusion occur in acute pancreatitis?
Yeah, as I already mentioned, there are many mechanisms, but the most common we have the that leakage from the pancreatic duct, pancreatic the vessels, which can lead to the effusion around it. Effusion, that is the fluid leakage around the pancreas, which can go to the uh, pleura. And one more we have the that is the diaphragmatic fistula, which forms many a times. And one more that is there is a blockage of the lymphatics. Sometimes what happens, there is a blockage of the diaphragmatic lymphatics because of the pressure of the pancreatitis. So it causes the blockage and it causes the fusion in that pleural region. So yeah.
What is the relation? Is there any relation of pain in acute pancreatitis with the food intake?
So yeah, as I told, in pancreatitis, there is a stomach. Stomach is very much distended. It will cause more pain to that patient. So pain is not that much. Ice cube, as I said, ice cube not that much indicated. But yeah, generally we put ice cube so that the pancreas rest and there can be less inflammation.
Thank you, sir. It was a nice session.